It's an absolute honor and a privilege to be here from a place way far away where when I land on Monday morning early, I will be greeted by somewhat more than 3 feet of snow that was not present in my front yard when I left. My only prayer is that my neighbor, who loves to use his snowblower, has taken, he has seen fit maybe to run his snowblower down my way, so at least we can get to the front door. But we'll see when we get home. Thank you, Ian, for the wonderful introduction. I'm not sure I deserve all those kind words, but you would make my mother proud at least. God rest her soul. So it is a pleasure to be here. This is, right now, marks the 10th time I've had a chance to speak in the last 10 days or so that I've been in New Zealand. So you're getting me warmed up, and I've had a chance now to use these same slides multiple times, but I think you're going to hear a message from me that's actually pretty consistent over time about the kind of things I think that we can do together to make surgery safer for all of our patients. And I'm going to talk about where some of that thinking comes from as I talk about our experience in South Carolina. But I also, at the end, want to wax a little bit, poetically maybe, about what the future could possibly hold for all of us, and again, providing the best care we can. So let me start by saying that this is the 10th year anniversary of the WHO Surgical Safety Checklist, which I think if you look across the course of many things that have come to surgery over the years, it was a landmark in terms of moving things ahead in almost every country in the world. And I'll show you some of the spread of that checklist, but it started, I think, to take us in a slightly different direction. Actually, I was just involved with a conversation a few minutes ago talking about the technical side of things. We were talking about prophylaxis for deep venous thrombosis and potentially to prevent pulmonary embolism. And I think that technical science has advanced tremendously. But one of the things that we talk about a lot is right along with all these tremendous discoveries, we really haven't gotten as good as we can be about actually delivering those kinds of things to our patients. And while the discovery that itself is really important, it's whether the patient has the benefit of it or not that really makes the difference, right? If the patient never gets the boots on their legs or doesn't get the stockings or doesn't have a program that gets them out of bed early after surgery or doesn't get medication appropriately, all the knowledge we have gets wasted. And I think this was one of the first tools that said we know a lot, but when we go and we look, actually, there's a lot that we don't do. Now, it was nearly 10 years ago, actually, that I was in New Zealand for the first time for me, and this is my first trip back since then, so it's a little bit, for me, a personal anniversary in returning here. So this is a WHO surgical safety checklist. You may never have seen a copy of the original version of it. This is the same one that sits on the WHO website today. It has been adopted and modified and put into use in operating rooms around the world. Its use, I will say, is highly variable from country to country. Some places follow most of it. Some places have it on the wall and haven't paid any attention to it in 10 years. But this is it, and this was the place where I think a lot of this work that I want to talk to you about actually started. Now, one of the things that we did in New Zealand had a place in this from the very, very beginning. In addition to having people sitting in Geneva amongst the experts, and there were people from New Zealand who were sitting in that room helping to actually craft that thing that I just showed you. Auckland City Hospital was one of the pilot sites for testing this tool, and that was what brought me here nearly 10 years ago. to work with Dr. Alan Mary, an anesthetist up there at Auckland City Hospital, and actually put together a small study to test this thing out. So we made it. It had all kinds of expert input, but before we were going to introduce it to the world, we wanted to see if it actually, first we wanted to see if anyone could actually use it. And second, we wanted to see if they did use it, did it do something? And you can see the results down in the corner, and I think what you can see there is in a group of about 4,000 patients before and 4,000 patients afterwards, that the tool actually worked. And I don't know how many of you have ever seen or heard of the book. There's a book that my partner back in Boston, Atul Gawande, we were partners together in setting up the little place where I work now called Ariadne Labs. He wrote a book called the Checklist Manifesto. And in the Checklist Manifesto, actually, if you look me up at the index, there's one quote where I'm quoted as being surprised that we had a mortality benefit from the use of this checklist. And while I never said what it said I said, I was surprised. We did not expect to see a mortality benefit when we tested this tool. What we were almost sure was that we would see surgical site infection rates drop, because we were really encouraging people to give antibiotics to surgical patients in an appropriate fashion, and we knew a lot of times either antibiotics weren't being given or they weren't being given appropriately. So we hedged our bets there, but as you can see, it wasn't just surgical site infections that went down. All complications dropped, right? Some of them are infections, no question. Unplanned return to the operating room went down, which I can explain, but we still don't really fully understand why that happened. And because infection and complications are related to patients not doing well at the end of their stay in death, it's not a surprise that death actually dropped with this. And this kind of work has been repeated over and over and over again in the last 10 years. And like I like to say to the people who I teach back at home, never believe the first study, right? Because there are plenty of things that look like they work in a single study. But this one has now been studied repeatedly over time, and in most cases was shown to actually work. So we've done, I think, a pretty good job creating soldiers of spread for this idea. The WHO obviously has put a lot of time and energy into spreading this checklist, but so have a lot of other people, and they've taken that checklist with them, and you can see that the penetration around the globe is pretty significant. The data that support this come actually from a little undergraduate intern who worked for me last summer and spent her entire summer on the internet searching every country in the world for presence of the checklist in at least one hospital. And some of these, it's adopted at the ministry level, but in many of them, its presence is really only seen down at the front line. Still, this shows that the geographic spread of that particular tool is actually pretty amazing. There aren't very many other things, save maybe cell phones and electricity, that have spread quite like this, particularly at this speed. This has spread in 10 years, which I think is a remarkable achievement, especially in something like surgery, which surgery doesn't always change so fast. Now, before I go on, I talked about multiple studies, and I could put slide after slide after slide of single implementations or sometimes 2 or 3 hospitals working together where the benefit of the checklist has been shown. Sometimes mostly around prevention of infection, sometimes actually preventing mortality. But this was a large study that was published in the same exact journal that we published the initial article, and it comes out of Ontario, Canada. And maybe a little surprisingly, actually the team that did this research was at the pilot site hospital in Ontario when the original test was performed. Now, I can tell you a little out of school that the checklist actually worked in the pilot site where they tested it in Canada. They had similar reductions in surgical site infections, not a detectable one in mortality. But this team in Canada decided what they would do was take advantage of the fact that the Ontario government said to its hospitals, to all its provincial hospitals, you must use the checklist. And we are going to give you 6 months to be able to put it into place and tell us that you use it. And this is a negative study. What it showed was at the end of the time, and they looked specifically at mortality. They also looked at surgical site infections. And what they showed was, in their period of implementation, including all of the hospitals that were in Ontario, there was not a demonstrable benefit that they could identify from this. Now, I don't know how many of you understand statistics very deeply, but I think there are other ways of interpreting this. The mortality actually did drop in this study, as did, at least directionally, all of the complications. Everything went down, nothing went up. The mortality change was significant at the 0.07 level, not 0.05. And so technically they were right. This didn't show a statistically significant difference at the 0.05 threshold, but it was mighty close. So whatever you want to think about this, it sits in the literature. I think that the WHO checklist, though, over time has been shown to contain all kinds of practices that just on the basis of good surgical practice, we should give to every patient every time. And I'm going to show you a little more accumulated evidence over time. Now, when we did the study, we promised the pilot sites that we wouldn't specifically release their data. So instead of giving them names, we identified them by letters, and this is the data that comes from one of the pilot sites called Site C. I have the permission of this site to say who they are. They were at the University of Washington in Seattle, Washington in the United States. And I think the results that you see up here say that maybe there was more to the checklist than just checking boxes, making sure that we're doing stuff. Because this is a hospital that actually had spent a fair amount of time working on giving antibiotics appropriately. Before the checklist was ever there, they were doing that correctly 98% of the time. The checklist actually didn't do anything to their performance, not in an appreciable way anyway. And we also looked at 6 other key indicators of safety that are important for every patient. They were already hitting it out of the park. And the checklist really didn't change their performance, kind of maybe held them in the same place. But what you can see is there's something else at work, at least at this one pilot site. Surgical site infection rates went down by half, death went down, and complication rates also went down. Now, it could be all kinds of things sitting in the background. Maybe they were doing other projects at the same exact time they were doing the checklist that might explain this. We're not aware of any of those things. And what I want you to get the wheels in your head spinning around is the idea that maybe this has something to do with the WHO checklist push for better communication and teamwork in operating rooms, because it asks at least 3 times to do more than checking boxes. It asks you to share important information. And what I want to believe from this, and I have more evidence to believe it now, is that that actually was probably making a difference, this communication and teamwork piece, right? So now I want to show you another study. This one actually comes out of the UK, and it looked at a handful of hospitals. I think it was 4. And what it did was it looked at how much checklist was being used versus what happened in terms of mortality. And what you can see is that, and I don't think it's particularly surprising, the more of the checklist you do, one part of it, 2 parts, or all 3 parts, the mortality rate is significantly changed when you do 3. So the more you do, the better the patient can do. So it kind of makes sense. And to me, reinforces the original message here. But what it says is, and I actually wrote an editorial once that said basically, if you don't use it, it cannot work. Or, to put it on its head, in order for it to work, you have to use it. And I don't think that's a surprise for anything in life. But this, to me, is more convincing data in that direction. Now, this is your checklist, or at least a checklist template that's used in one form or another, I guess, across much of New Zealand. And you can see that it falls to the same three important things: the sign in, the time out, and the sign out. And I can tell you now, from talking to some people here in New Zealand and from talking to people who have tried to put this into place around the world, that the time out, I think, is probably the thing that's the most robust in most parts of the world. Some places struggle with a standardized kind of a sign-in, and other places struggle with the sign-out. And I think the sign-out, particularly in the United States, is a huge problem. And a lot of it has to do with the operational things that are going on in an operating room when you want to share that information at the very end. I think there are probably some creative ways to work around some of that, but it's a challenge for virtually everybody. All right, so I started this thing off with a title slide that said the South Carolina experience. South Carolina is way far away. It's on the southern east coast of the United States. It actually has a climate that's not that different from New Zealand, except that it's a heck of a lot more humid most of the time, at least than I've ever experienced here. And what I don't want you to do is dismiss everything that I'm going to say to you because it's not from here. And I want to start to convince you a little bit of that by showing you that the two places, very different. Different cultures. As a state, they voted for President Trump, which I don't think would ever happen here. But so politically, you guys are in different worlds. But in terms of the rest of your world, it's actually not all that different. This is a bigger country, no question. And I can tell from having traveled around all of South Carolina and now gone from one end almost to the other end of New Zealand, this place is way bigger. But your populations, although they may be a little more spread out in New Zealand, are actually pretty close to the same. And surprisingly to me, the number of hospital beds that each place, in a ballpark kind of a way, each place supports is pretty close to the same, right? Sitting right around 12,000. And both places are diversity challenged places. South Carolina is exceptionally diverse. It was one of the reasons that actually we wanted to do our work there. It is way more representative of the way the United States looks than Boston. Boston doesn't look, we don't have that kind of diversity in much of Boston. But in the southern parts of the United States, we absolutely do. And I know there's a lot of diversity here in New Zealand. And we were both discovered, at least the European discoveries of the place probably occurred in similar, close to each other, within 20 or 30 years. So there's a lot of things that are shared in common. And then, this didn't come to me until I came here, but both places love tea. In South Carolina, they call it sweet tea. Do you guys have sweet tea here? Probably not as much. That's what they drink there, sweet tea over ice, which is probably a little bit different than the way most people take tea here. But everybody loves their tea, and probably that goes back to the English roots in both places too. So let me tell you about work that we've been doing there since 2010 about. We at the Harvard School of Public Health teamed up with an association of hospitals in South Carolina. It has a membership of about 65 or so institutions, all those little black dots that you see. So they are representative of most of South Carolina. What's unique about this association is they even have government hospitals in this, which is a little bit unusual. Our government sector is about the same size as your private sector, actually. So we're completely backwards from the way that you are. But that hospital association is broadly representative. There are medical centers where a lot of academics are in at least 3 different places, spread geographically across that state, and then there are a lot of private institutions, right? The CEOs were the place where we started this work. So we went out and went to hospital leadership and got their commitment. They actually all signed a big poster board that sat in the lobby of the hospital association, which was in a city right in the middle of the state. And they signed their names in public, and they signed their names for everyone to see. And within about 2 months, every single CEO had put their name on there with a commitment that they were going to put the checklist into place in their hospitals. Now, I can tell you that a CEO commitment is fantastic, but is not the end of the story. It takes people on the front line, people like a lot of you, to actually make these kind of things happen. And so some of the results I'm going to show you will show a disconnect between the CEOs. But I think having leadership from the very beginning makes a difference. So we're now 8 years almost into this kind of work. So we've got a lot of experience now across an entire state. This is what we did with them. We educated them, we coached them, and we monitored them. So the educational part was webinars. Those hospitals are scattered. It's hard to break people out of operating rooms and sit them down in a meeting room like this, like I'm sure it was a struggle for many of you to get to this kind of a get-together. We had that same struggle down there. So we took it to them as best we could. And we used the internet and webinars. We did have some in-person meetings. I will be honest, in the United States, we were lucky if we could get 1 or 2 clinicians in the room. It was clinicians meaning anesthetist or surgeon. We always had a room filled with nurses because they seemed to be the ones that the hospitals could send us. We added to that a lot of personal contact. We actually visited, our team, or representatives of our team, visited every single hospital across that state. There were a lot of miles put on some cars as we went driving around. Now there's an advantage there that you can go from one side of that state to the other in 3.5 hours. But still, it was a lot of work. We went into their operating rooms and we watched them use the checklist. If they weren't using it, we encouraged them to use it. And if they were using it, we always coached them on how they might be able to do even better. And then finally, this whole thing was undertaken with an eye toward being able to talk to audiences like you and tell you what happened. So we were monitoring, and we got a special gift from South Carolina in the way they captured data on all their patients. They are one of maybe 4 or 5 states in my entire country that has a unique patient identifier. So we can actually track every patient encounter with our incredibly complicated private healthcare system, right? That is almost unheard of in the United States. So we could watch patients go from hospital to emergency department, even into another hospital with a complication. We could track them back and forth. And that was a real gift to us. The other thing they have, similar to here, is a really robust vital statistics group. So when patients pass away, we know that they passed away in South Carolina. In a lot of other states, the records are honestly terrible, and a lot of times you can't tell whether a patient lived or died. So this shows you on a little timeline the course that we took, and showing you this is most important for me to tell you what qualified the hospitals to be in the group that we split off and analyzed separately. These hospitals were encouraged to give a culture survey, a patient safety culture survey, and we encouraged them to do it twice, once at the beginning and once at the end, because we wanted to be able to say something, and I'm going to tell you some of what we learned because of it. We wanted to be able to say something about culture, right? And you can't say anything about culture really if you can't measure it somehow, and you have to be able to measure it multiple times. Well, the hospitals that we call completers were ones that were able to do the culture survey twice. Now, we got more than half the hospitals to do it once. And that's another thing that it's really important for everybody to understand. We didn't have the force of anything to get people to do anything except to plead, beg, cajole. It was all voluntary. There's no government requirement for doing this kind of work. We didn't have the force of any of that. So what you see is hospitals that worked hard because they thought they should work hard for the sake of their patients. This is a graph that goes from 2008 all the way up to 2014. And by the way, right now, we're adding the next 3 years of data, and I don't have it for you yet, but I promise to send an update when we see what happened over time. But what you can see here, it's split into 2 pieces, and at the middle of it is where we were doing that education and coaching, right? The entire time we're measuring, And this is focused on mortality, because we knew from the first study and others since that mortality reduction is something you can probably see with this tool. And what you can see is that those hospitals, the 14, are sitting right together with all the other hospitals in the state until the work starts. And once the work starts, the curves start to separate. And by the time you move out to a year or two after implementation, the curves are now distinctively different. Different care is being provided in two different places. So if you go all the way over to where it actually puts numbers on things, you can see in this group of patients that the overall surgical mortality sat just north of 3%. In the ones that did this work, it ended up down in the 2% range, with the other ones from beginning to end actually basically unchanged. Now, I said this the other day, and I really believe it. If you worked in the 14 or you worked in the other ones, that degree of change is almost impossible to feel, right? That's the difference between, well, it's a little above 3 to, someplace in the high 2s. You're talking about like one patient in 400 that lives instead of dies. And yet if you take it and extrapolate to the whole state, it's somewhere around 200 patients a year benefit with that kind of a reduction. The reason for showing it to you is a couple-fold, but the biggest one probably is this kind of thing is possible. It's hard for people to feel on the front lines. But there are other things that are easier to feel on the front line. And that's where I want to shift gears right now, to talk about culture and culture in the operating room. So I think this care makes a difference at scale. It makes a difference to our patients. There are South Carolinians walking around today who probably wouldn't be walking around today had it not been for some benefit that they got from using the checklist. But I think at the bottom of it, this is what matters a lot more, and actually not just for the patients, but for the people who actually provide care in the system. Culture matters. Having a great place to work and feeling like you're doing good things benefits you and your patients, right? We didn't discover this idea. This is a paper from back in 2009, I think, that looking at surgical teams do their work, which I would say is the way that they do it, is their culture and its relation to outcomes. And what they showed was people who had better behaviors in their operating rooms had better outcomes for their patients. Now, for somebody like me who believes this so deeply, that's kind of a duh. But this showed it, right, in a fairly significant group of patients. This is another study that was published back in, I think, 2016 actually, but looking at some data from 2015 in hospitals in the state of Minnesota. This was specifically done around a project that was focused on reducing surgical site infections in patients undergoing colon surgery in particular. So you can see that the rate of surgical site infections is actually reasonably high. And what you can see here is baseline culture survey data. But again, there's this powerful relationship between the state of a culture and the number of infections. Now, I think we have to convince ourselves that there's got to be reasons for that. And I think a lot of the reasons actually are pretty subtle. I'm going to guess that as you move down that line toward higher safety culture scores, you have people who work better together as teams. You have people who cross-communicate. You have people who speak up when they see the sterile field violated or some other safety problem emerge, to the point that across here that you can see a big change. I mean, that to me is an unquestionable result. All right, so I want to take you back with me to South Carolina and ask this question. Does culture in the operating room actually matter? And what this is doing, I'm going to change my glasses, I think. Oh, actually, I can turn around a little bit here. This looks at a couple of the questions that are on our safety culture, the one that we gave. And look at the first one. It says, you can't read it, I would feel safe being treated here as a patient. So this is asking the staff in the operating room, would you have care in your own hospital? There were hospitals in South Carolina where 40%, 40, said they would not jump up on the bed, that they were taking care of the patient right now on. To me, that's frightening, that people wouldn't want to have care in their own hospital. But what this says is, if you can say that, your place is actually safer. There's a reason why you don't want to hop up on the bed, because it's more dangerous. It's 17% safer in terms of dying there. Or for the nurses, 13% safer, that the risk is 0.87, with 1 being the normal, it drops it down by 13%, here by 17%. And then the other question there is actually, to me, the responses are interesting. If I were having an operation, I would want a surgical safety checklist used. That actually turns out to be most predictive of surgeons who are working in hospitals who are safer. I don't quite understand that, but if the surgeon says, I want a checklist, maybe it means they're bought in, their institutions are bought in, and that they end up being safer places. You can see there's 11% reduction in relative mortality. All right, so when we do the culture survey, we actually break the questions into groups. And the groups have to do with an overall way of thinking about teamwork. So you can see on this slide, respect, clinical leadership, and assertiveness. The responses to the surveys, have any of you taken a patient safety culture survey in your own hospitals? Yeah, a couple at least. All right. The way that you're normally scored is either on a 7-point scale or a 5-point scale that goes from strongly disagree up to strongly agree, with some kind of gradation between the two. A 1-point change, so taking you on average from agree to strongly agree, is associated in the respect dimension with a 22% decrease in mortality. If you think your place where you work, if you're respected and you work in a respectful environment, the mortality is lower. If you think that the clinical leadership that you see manifest by the anesthetists and the surgeons is the way that it should be, 14%. And if you feel like you can speak up in your operating room, there's almost a 30% difference. If you feel like you can't, then those hospitals had a 30% higher mortality rate than the hospitals who didn't. And this is actually tied to exact questions on the survey, but you can see the same kind of thing coming through. Potential errors or mistakes are pointed out without raised voices or condescending remarks. So if something happens and you get feedback from the people around you, it's not rude and snarky. People are actually kind without raised voices. 16% decrease in mortality. It's difficult to discuss medical mistakes. If you work in a place where people, something goes wrong and nobody wants to talk about it, 33% increased mortality rates. And it's difficult to speak up when I perceive problems with patient care. So you're there and you feel like you can't speak up. 18% increase in mortality rates. So what this says to me is all these things matter. And they're related directly sometimes to whether patients survive or not, right? Okay. Surgical checklists and changes in perceptions of safety and teamwork. And my takeaway, what I'm going to show you now, is from the 14 that gave us the data so we could answer a little bit that question. Can you change culture, right? And so I'm going to show you that, at least in the 14, people there thought you could change culture. Now, the first thing I want to do, though, is make a little stop here and show you part of what I think the why was for South Carolina. Just like here in New Zealand, so I showed you the green checklist with the 3 columns. South Carolina modified its checklist, and they asked for 2 things that weren't on the WHO checklist. One was they were used to using the word debriefing in their hospitals already, so they wanted that to actually get called out. But the other is that they wanted to add this statement that the surgeon could make at the time of the timeout. Does anybody have any concerns? If you see something that concerns you during this case, please speak up. Now, sounds like weird words, and I'm going to guess when surgeons say it for the first time, they probably use different words than this, But the first few times that you might say that as a surgeon, it might feel a little strange, but there's a really important reason why I think it made a difference there, and it makes a difference. And that is that we, surgeons, do not recognize that we actually intimidate people. I think a lot of us don't mean to, but once you start to get gray hairs and maybe speak up a little loud a few too many times, people are afraid to say stuff to you. And I've noticed it particularly with younger theater staff that, you know, it only takes 1 or 2 times of getting yelled at or embarrassed or whatever for them to adopt this like cone of silence that they live inside, even when they see stuff that they're worried about. Back in our country, the Joint Commission, which does a lot of investigations of wrong site surgery in particular, over half the time in their investigations, someone in the operating room knew something bad was going to happen. Somebody, half the time, somebody could have potentially stopped the bus, and they didn't stop the bus because they were afraid. So I think that calling it out like this and having surgeons actually say, look, I can't watch everything that's going on. I'm a human too. If you see something, please speak up. That has a difference in what goes on. Now, I will warn any surgeons who are in a room and you try and do this, you are probably going to experience a little bit of noise. And that means probably somebody's going to say something to you that isn't going to prevent anything significant from happening. And it's really important that surgeons take that well. They thank the person who said it, and then they treat them respectfully. If you don't, you might as well not ask this question. Ask people to speak up and then jump down their throats. That'll never help anybody. All right, so what happened? Well, I told you about all those different dimensions. We looked at those dimensions in the 2 culture surveys. And what we found was, in every single dimension, the change that we saw was statistically significant and in the right direction. So respect, leadership, assertiveness, coordination, and communication all got better across those 2 surveys, right? And all got better in a way that statisticians would say was significant. But the one I think that's the most important is you can see the biggest relative change is around communication, which means to me they were using the checklist as a communication tool, right? And the people in the room could feel a difference in the communication, and it was statistically significant at the end of the day. So you can change culture, and culture matters. Culture is associated with mortality, and if you work hard at it, you can actually move the culture in a more positive direction. Now remember, these are the same 14 hospitals whose mortality changed over the course. Now this looks at the culture scores and how they changed in those 14 hospitals. And you can see not every hospital is sitting in that right upper quadrant. That's where we really would want everybody to be. But the vast majority of the hospitals are sitting up there, and if you, that line there is a trend line that's drawn that shows there is a positive movement up and to the right towards safety and a better culture. That's our own data. Every single one of those was a hospital. All right, I want to end with just a handful of little quotes that I think it uses the words from South Carolina better than I could probably say any of these. Since we began, this is from a surgeon, since we began a journey last year to implement checklist utilization for every patient, every time, there's been a drastic change in the level of surgeon and staff involvement during the timeout process. Because of increased emphasis on the checklist, each person in the room has an opportunity to speak and bring up any concerns they may have before incision and at any time during the surgery. So this is a surgeon who bought into that statement. This creates an environment where all members of the team feel invested in the care we are providing to the patient during their surgical experience. That's coming from a surgeon. All right, another surgeon. The checklist precipitated a shift in our rooms from closed top-down communication to a more open and inclusive structure. Basically the same message. This from a nurse. I feel like the communication between OR staff, anesthesia, and physicians have vastly increased. The increased communication about anything that may be needed for the procedure helps every member of the surgical team feel more involved and prepared. And then finally, from a hospital executive, because I think that, they have a big picture. We actively tried to involve the hospital executives in the project. We wanted their support. We actually needed a little bit of their money and their time. They had to pay the people who came to the meetings or to sit on a webinar on a computer, and the ones that saw value and supported the work were the ones that felt like this. We had early adopters and skeptics, just like any other facility. We employed peer conversations, audits, coaching, video training, staff discussions, workshops, and other methods to bring our staff on board. It has been a slow and methodical process that has produced the results that we hoped for. So I think from all the work that we did in South Carolina, there are three big takeaways. The first is use of tools like a surgical safety checklist are associated with reductions in surgical mortality. Now, we could stand up here all day and have scientific arguments about causality and what's associated and what's causal. And honestly, I can't win you any of them. But I believe this in my heart, that well done, this is a way to improve the standard application of a lot of things that we know that we should do. The safety culture of operating rooms matters, and better culture predicts better outcomes. Culture matters in your ORs, and what happens to your patients hinges on the culture in your operating rooms. And then finally, safety culture can be changed, and positive change is associated with the implementation of a surgical safety checklist. Now, I want to close by saying one more thing, and that is the surgical safety checklist is the beginning of this work. You're going to hear more things to follow me here about some exciting work that's going on across your country. But this is a place to start. It is not a place to end. It is something I think that in one form or another should be incorporated into routine surgical practice everywhere, but it doesn't stop here, particularly for well-resourced countries like ours. There's more that we can do that'll make this trip even more productive for our patients at the end of the day. So, thank you very much for your attention.